No, I'm good. I don't want to feel guilty about
They're even honey roasted.
about eating your food.
Sharing the food.
There wasn't a page. Charlotte's afternoon. They did. The session. They really didn't bother. It was a wedding.
I don't know. They got 5 minutes.
We're sharing.
I was kind of skeptical as whether or not I was going to miss it. But we still have the baseball practice and I'm going to do it.
We finished 16, didn't we? Did we finish 16, Ellen?
Yes.
Okay.
Now we're on this, regulatory thing.
Oh, yeah.
That's what she just
We'll give them their 4 minutes to get here and then they get started.
We finished pharmacology and their occupation and the
Yeah. I think this is where we're at. I hate when I pick up a water, thinking that's getting a water.
Oh my gosh, today I was in Diane's room talking about the patient coming, and there's this thing flying around, and as I'm talking, it goes down my throat. I actually swallowed anything, and I'm choking, but it don't come back up. Well, then, I swear, it was like right there. It's right there. It's right there. Oh my goodness.
I'm trying back out. Get me out of the dark hole.
They're pretty.
Did they tell me they were going to be late, gone, whatever?
I have no idea. Waiting it so that how berries
Oh,
were
there it is.
outside.
About started without you guys. Yeah.
We're gonna be, the first graders didn't get to go outside.
They still have 2 minutes.
Yeah, the first graders didn't get to have theirs because of the weather conditions, and so Miss Burgess, where they can walk in. And they were gonna hide you to that.
When's 4/14? That's tomorrow? No, I was going to talk about that. I know that we have a couple people that can't do the lab on the 20th, so we are going to adjust it a little bit. Yes, I did.
Okay, so freaking out, what is your 17?
Yeah.
I was freaking out earlier today. And I looked, when I walked in, I said, you have 5 days and you changed, so you have to come do it. What?
Oh, it's the 17th, it's supposed to be due today.
Well, but the test is this, boy.
Black acid.
Hey, I only had a test list, right? That was all I had left. I couldn't stay awake any longer. You know, it's all
No, I have. I'm.
I'm sorry, dude.
No, that's fine. I'm just trying to think how to say this.
I'm hungry. I am.
You gotta think how to say it, just say it.
You should not be drinking red fuel, shame on you. That is
You can give it to me. I'll drink that for you.
not good. I'll share everything that I own,
Rob's not
except
hungry.
for that Red Bull.
He's not hungry tonight, baby, sir.
She said she was getting hangry, so.
You can have some of my water, but you ain't touching my Red Bull. Yeah, yeah.
I almost went and got one, but I was waiting for Serena to get here so I could go buy her some food too. But she's like, I don't need anything.
Right over here, I swallowed that drug today. I'm pretty good. My proteins look pretty done.
So on schedule wise, if you're getting caught up, you're real close or whatever, I will continue to adjust dates as long as you guys are staying caught up. There's some chapters that should already be done. We're looking at 13, 14, probably 15. I'm going to start getting tighter on the 2, 3, 4 chapters back date. I'm going to stop extending those, but I will extend the current chapter. You get into a situation where you got the post-test left. And that's all you got. You didn't make it. Don't stay up late. Just let me know. I'll open it. But try to make it, because it is a pain in the ass for me to change the due dates on things. And so, and like a lot of people will send me an email or something, and I'll be at home over the weekend. Well, I got to the point where I don't even look at a freaking computer at home. I don't have one at home, and I can't do it from my phone. If I need to look at anything, it's usually on my phone. And so, I can't change the dates from home. And so, they need it opened up, and it's like, well, okay, it's gonna be a few days. But anyway, like I said, I will still work with you guys on, especially if it's just that chapter. You for some reason get one chapter back, but we're gonna get to the point where if you're 3 chapters back, you know what, you probably just need to take the class another time. The reason is because if you're 3 chapters back, you're not on the current information, and now we're at some pretty important things. And we're far enough into the class. It's a fast class, but we're far enough into it that I really need you guys to stay caught up. So anyway, I'll just shave so you kind of miss the beginning. If you're a chapter or so back, I'll change that date. But I'm kind of all right. But I'm it'll take some convincing that you're really gonna try hard or whatever if you get more than a couple chapters back. So anyway, that being said, if everybody could send me an email when you won't be able to make it to a lab in the next. I was going to do that CPR lab on 4/20. Is that right? Somebody already had a speaking engagement already, and it's the person that's always attending class. I'm not going to have that lab on a day that she's had a speaking engagement. So I'm gonna work on it. So send me days that if there's a day in the next week to 2 weeks, I guess 2 weeks, because 4/20 is a week away. Mm-hmm. So if there's a day you can't have, that, gosh, I really got to be gone for whatever reason, let me know, and I won't schedule on that day. Now, if it comes back and every single day has somebody that has to be gone, then we're gonna have to figure something out. But the thing about it is it's a CPR. We're gonna do CPR. I'm not gonna do the video for the CPR. I'm gonna stand here and teach it. You guys are actually gonna do the CPR. We're gonna do compressions, but then it's going to be, we're going to start running mock codes where you guys will run do CPR with your team member or maybe one other person, so you guys can kind of see what it's like to run a cardiac arrest as a basic and practice that. So yes, I want everybody to be here because it is going to be a little bit more than just a CPR class. We'll pull out our monitor. Now remember, it is going to be scenarios, so there will be some hiccups in it. I can't perfectly mimic a dead guy. This guy, sometimes I run into some snags and running him, and so there may be some pauses in the whole scenario. But the good thing about him is I could set him up to where maybe I do sneak in after you shock him, his heart rate comes back or something, and how you guys check that. And so I really want everybody to be here. And in fairness, it's a lab. Kind of whenever we signed up to do this class, I wanted, the big thing with doing it this way is I wanted you guys to be here for labs, and that includes a CPR lab. In fairness, because everybody in here is coming to class. You guys are all coming to class, and so I figured that it's just fair for even if you do already have a CPR card, let you come, because we're going to do a little more than just CPR, or that's the plan anyway. So the lab will probably we'll probably push the 9:30 mark with whichever lab day we choose, just because it's going to probably take us about an hour and 45 minutes or 2 hours to do CPR. Then a break and running some scenarios and 3-man teams. You're probably looking at 15 minutes per scenario. So we'll be here till 9:30 or maybe even 10. But the thing is I don't make you guys do that very often. So anyway, we'll get started. I did say that I did want to not rush these chapters. So I don't want to try to force getting through this chapter and getting through the next one ahead of schedule. And kind of look at the schedule. We have a day that we have a test scheduled, and we have a day that we had a lab scheduled. So that gives us two flexible days that if we need to push our lab back a little bit, we can. But I want to kind of slow down a little bit on this, give everybody a chance to take in this information, because the respiratory and cardiac will be big sections on your national registry. So all right. So breathing difficulty. I believe this is where we stopped last class. You guys cool? This is a little cold in here. That's a little bit. So breathing difficulty. Breathing difficulty. Patient's subjective perception, feeling of labored or difficult breathing, an amount of distress felt may or may not reflect actual severity of condition. So you guys hear me talk all the time about the girl that just broke up with her boyfriend. She can't catch her breath. She can't breathe. And that kind of comes into the patient's subjective perception. She has a perception that she can't breathe. And that kind of goes with the fact that amounts of distress felt may or may not reflect actual severity of condition. So she feels like she can't breathe, she can't catch her breath, she thinks she's going to die, when really she's not. It's not a severe issue. We just need to calm her down. It's not just the teenage girls and sometimes teenage boys that have this. It is, I lost my job. I don't know how I'm going to pay my next bill. My kids are going to go hungry. See, yeah. And so what you end up with is they start thinking about these things. It's just a subconscious thing. All of a sudden they start breathing faster and faster. Next thing you know, they don't feel like they catch their breath, and now they're in a full-blown anxiety attack. And so sometimes you just have to calm down. These aren't severe calls, but they are. The patient does have a perception that they can't breathe. So I'm trying to think of some opposite scenarios of that where they don't think it's that bad, but most of the time that's more of a denial. If you don't think it's that bad, when actually you have a 78% O2 saturation. So, yeah. So assess the patient to ensure that he meets the criteria. I don't know why they're talking about CPAP right off. I don't know if we accidentally just skipped some slides or not. I didn't skip them, but.
Well, this has a patient assessment deal, and then it goes to CPAP.
So yeah, we'll see if they kind of get us back in order here. I will note one thing about this picture. If you walk in and see a guy sitting like this, what position is this? Tripod position, right? He is working to breathe. He's down there, bent over, and you walk in and see somebody like this. Until proven otherwise, this is probably going to be a critical patient. All right, so he does appear to be in severe respiratory distress. It looks like they even have him look a little diaphoretic there, but I can't really tell. This might be him. So breathing difficulty with your assessment. So onset, when did it begin? Provocation, what were you doing when this came on? Another thing with provocation, I think is better. Does anything make this better or worse? That question could give you some good information. But also, what were you doing whenever this started is a good question. Yeah, I was just sitting here watching TV, and I started having shortness of breath. It's different than I was on my 17th mile of the marathon, and I started having shortness of breath. All right, It's two different provocations. So quality, do you have a cough? Are you bringing anything up with this? That's a good question to ask, and you hear it asked a lot. Sometimes I kind of wonder if the people know what the significance of the answer is, the medics that are asking it. So, are you coughing anything up? Yeah. Oh, okay, great. And they just kind of go on and skim over it. Yeah, I am. Have you been having a yeah. Yeah, or maybe the next question with that could, well, have you noticed that you've been having a fever or anything? Now you're going to try to see if it's a respiratory tract infection or maybe just some bronchitis or, CHF. Yeah. And so I do wonder whenever somebody will ask that question, they get the answer and they just kind of go on. And obviously they report it sometimes, but I wonder if they know why they're even asking that. So, radiation. Do you have a pain or discomfort anywhere else in your body? Does it seem to spread to any other part of your body? So that's a good question, because if they're short of breath as their chief complaint, may not be the significant thing going on. They might be having a cardiac event. Well, do you have any other pain in your body? Oh yeah, I have this little bit of chest tightness with it. Okay, does it radiate? Yeah, it radiates into my left arm, but I just really can't catch my breath. Well, great. They might be thinking they're just short of breath, but now you might be thinking, you know what, this may be a cardiac event. So, breathing difficulty severity on a scale of 1 to 10. How bad is your trouble or your breathing trouble? If they sit there talking in complete sentences and they say 10, they don't really understand the whole scale. But then on the flip side, you get somebody that can't talk and just 1. So people are on some extremes. Sometimes you get what you think is a good answer, but this is more of a patient's perceived. And so what you use this 1 to 10, the scale of 1 to 10 for, just so you know, you give a breathing treatment, and they said they were at a 10, you give a breathing treatment. Oh, I'm so much better. I'm a 5 now. Well, that shows that your treatment has helped them, whether it's psychological or in fact helped them out. You're able to gauge that, or you're able to put that down on your chart, that the breathing went from a 10 over 10 to a 5 over 10 with albuterol. And so it's kind of your gauge on how your treatments are helping your patient. So time, how long have you had this feeling? If they've had it for 2 weeks, it may or may not be an important or a critical call, but let's say that's just been going on for 30 minutes and you have these other signs and symptoms. That to them, they perceive it as a little worse than that person that's waited 2 weeks. But man, you have that denial. People with serious conditions have denial. And so that's why we run cardiac events sometimes 6 to 12 hours later, is because they deny that could be going on with them. And everybody here probably could relate to it. You have that weird pain. Oh my gosh, it's a heart attack. Yeah, no, it can't be. And you go on with your business, and most time, we're fine. But just a little. So observing some things, and we talked about this already. Observing altered mental status is going to be a telltale sign that their breathing is inadequate, whether it's in rate or depth. It could be either. But for whatever reason, they're hypoxic, and so they're having altered mental status. Unusual anatomy. So a barrel chest would be indicative of a chronic respiratory condition. Emphysema. Sorry, I couldn't think of it. The emphysema patients typically have a barrel chest. And then patient position, tripod position. Whenever you walk in and see it, like I said, until you could prove otherwise, this is an acute patient. They're in severe respiratory distress. And then sitting with feet dangling and leaning forward. Leaning forward, are they leaning on their arm or on their hands and their knees? Observing work of breathing, so retractions. Does it give you a good definition of retractions? Do what?
It says retraction.
It just says retraction. Retractions are basically the use. you're really using a lot of accessory muscles, and you're seeing that retraction in that chest wall. Use of accessory muscles is a telltale sign. Flared nostrils, this will be you'll see this a lot in your pediatric patients. Pursed lips. Pursed lips, they're doing what's called self-peeping. So they're trying to keep that pressure up in their lung. Typically see this with your asthma patients whenever they're having an asthma attack. They do the pursed lip breathing, and what they're doing is just trying to keep that pressure up. It makes it easier for them to breathe. Number of words patient can say without stopping. I don't ever count the words. To me, they're either talking in complete sentences or they're not. If they can't talk in complete sentences, they're like, I was walking down the road and I just can't catch my breath. That is no different than I can't. It's basically the same thing to me. They're not able to talk in complete sentence. Now, obviously, the person who's only able to say one word before trying to catch their breath is having a perceived harder time breathing than the other. That's not always the case. So I lump them into two groups myself, but that's me. Observing, pale cyanotic or flushed skin. Remember that cyanosis, that bluing, or the pale skin, so that the blood, you have vasoconstriction, all the blood's kind of shunting more towards the central versus the periphery, and that's why you have that pale skin. Flushed skin, I'm going to guess is you're looking more at possibly your asthma patients or your CHF patients. Is that kind of what they're saying in your book? So, pedal edema. This is a good differential diagnosing thing for respiratory stress. If you hear the wet breath sounds, if you will, go down and look at their feet. They have pedal edema. Good chance is they have issue with CHF versus pneumonia. Now, if they're running a fever and have pedal edema, maybe they have both going on. So, then sacral edema. Oxygen saturation or SpO2 reading less than 95% on the pulse oximeter. Please, I've said this 1,000 times and I want to drill this home. Make sure that pulse oximeter is reading accurate. Make sure the pulse matches what the pulse oximeter says so that you know that 78% O2 stat is accurate. If the pulse, what the pulse is on the pulse oximeter if their patient's pulse and the pulse on the pulse oximeter doesn't match, then that pulse oximeter reading is incorrect. Okay, you want those pulses to line up or be very close to know that your pulse oximeter is correct. The other thing is if it's 78%, they're cyanotic and having trouble talking in complete sentence, most likely that 78 is a good read, right? So don't waste too much time on it. But if they're, they just don't really look. They don't have that look, and you guys will kind of learn what that look is when you start working. That I need to do something. Look, they don't really have it, but it says 78%. Maybe they're a little short of breath. This just doesn't add up. Then go ahead and investigate that pulse versus what the pulse oximeter says. So here's a good little chart of different things going on with breathing difficulty. So altered level of awareness, unconsciousness or dizziness, fainting, restlessness, anxiety, confusion, and combativeness. So you have some altered level of consciousness or mental status changes. Brings me to the question. You have that syncopal episode, that patient that passed out. So did they just have a syncopal episode, or did they have another more serious event prior to the syncopal episode? And so don't always write the syncopal episode off as, they just stood up too fast, or they locked their knees, that type of thing. Or we don't really know what happened, just this rare syncopal episode. Here's something that could help you with that. Well, but grandma's been having she has these every once in a while. Okay. So now we could kind of go with a syncopal episode versus, no, she's never had anything like this. Well, you know what? You really need to go get checked out. Some things to think about. I guess what I'm trying to say is don't get distracted on the one issue going on, the syncopal episode, when there may be a more serious condition going on. Cyanosis, looks like they're trying to point to the lips and onto the nose. Straining neck and facial muscles are a sign of difficult breathing. Tightness in chest, so stabbing chest pains in some patients. I see that more with pleurisy than I really do with my emphysema patients. More time they're just having a hard time catching their breath. Straining intercostal and abdominal muscles. Numbness or tingling in hands and feet. Flaring nostril and pursed lips, coughing, crowing, high-pitched barking. And respiratory noises, you can have wheezing, snoring, stridor. And then this guy is in a tripod position, hands on his knees, kind of bent over, trying to catch his breath. Observing noisy breathing, so audible wheezing heard without a stethoscope. I think I told you guys, most time when you hear audible wheezing, most of the time it's stridor. You can have audible wheezes, but they sound just a little different. I would hate to try to make the sound. The stridor is going to sound more coming from the throat area, whereas the wheezes are going to be more of a clean type thing versus a it's a completely different sound. Most time whenever even experienced medics walk in, they say audible wheezes, they actually mean stridor. So gurgling, snoring, crowing, stridor, and coughing. Auscultating, long sounds on both sides during inspiration and expiration. Sometimes you'll have wheezes just on one. You'll only have inspiratory wheezes or expiratory wheezes. You want to note that and pass on that information to the receiving hospital. Reassess the patient's, man, this is all out of whack, isn't it, my pictures? So after your treatments, you want to reassess the patient's level of distress and vital signs. We'll just roll with it. You want to see that you're, what's that? They started, like, one of them was like 3, this one's like 6, and I don't know, whatever.
This is the last thing in the book.
Yeah, I don't know why they're doing that to us. So reassess the patient's level of distress and vital signs. So auscultating, so wheezes, high-pitched sounds created by air moving through narrowed air passages. Good definition. Crackles, fine crackling or bubbling sound heard on inspiration and caused by fluid in the alveoli or by opening of closed alveoli. Typically, you hear them best in the back, crackles in the backles. Bronchi, and the bronchi, you're going to kind of hear it more in the chest area. Is lower pitch sounds resembling snoring or rattling, caused by secretions in larger airways. Stridor, high-pitched upper airway sounds indicating partial obstruction of trachea or larynx. Evaluating vital sign changes, which may include increase or decrease pulse rate. So initially on a respiratory distress, you're going to have an increased heart rate. As it progresses, as things get worse, as they start to circle the drain, they're fixing to die, they're getting ready to go into respiratory failure or respiratory arrest, their heart rate will drop. It'll continue to drop until they go into cardiac arrest. That's no good. You don't want that. Changes in breathing rate. So initially on a respiratory distress, that breathing rate increases. But as they tire out, and it's real scary when you walk in and you see somebody tiring out, all of a sudden their breathing actually slows down. It's still labored, it's still very labored, but they're real tired. And a lot of times whenever you say, as a paramedic, you say, you know, are you getting tired of breathing? Yes. You want me to take over for you? You want me to intubate you? A lot of them have been in this situation before, and the answer typically is yes, because they know that they can't maintain very much longer. So these patients, for you guys, nasal airway, and bag valve mask to assist the ventilation. Okay, that's about the best you could do. If they don't have a gag reflex, I guess you could drop in a king airway, but I wouldn't attempt it. I would just do nasal airway, bag valve mask. If they do continue to deteriorate, go unresponsive, then I would definitely go king airway. Changes in breathing rhythm. I'm hoping that they give us some examples of different rhythms later on and what they're indicative of, but I'm not sure that they will at the basic level. So, I mean, I mentioned them a few times, but I don't really want to get into them too much without the textbook, without you guys needing to know it. So hypertension or hypotension. So this is kind of the same thing. Initially, you have it also depends on the problem going on, but typically on a respiratory distress, say like CHF, even asthma attacks, anaphylactic reactions, you're going to have an increase in that blood pressure. As things progress, get worse or whatever, that blood pressure will start to come down as they start shutting down. Breathing difficulty. So assure adequate ventilation. If breathing is inadequate, begin artificial ventilation. If breathing is inadequate, use a non-rebreather mask, or if breathing is adequate, use a non-rebreather mask at 15 liters per minute. There's 15 on the old regulator. Yeah, use settings is defined in your protocols. I'm just going to be completely honest with you. If you have these patients that are in this state at respiratory distress where you're thinking that you're going to have to put them on high flow too, I prefer you guys to really think about using CPAP, unless there's a reason not to use it. There's a contraindication not to use it. CPAP helps out a lot. Ah! There it is. Place patient in position of comfort, administer prescribed inhaler, and administer continuous positive airway pressure, CPAP. Kind of an explanation of what CPAP is. It's a continuous pressure, as the name states. So it provides a continuous pressure on inhalation and exhalation. What that continuous pressure does is keeps the alveoli open and it keeps them from collapsing. So now it's easier to get breaths in. Now breathing against that pressure, initially it feels kind of hard. But once they get used to it, that difficult breathing against that mask goes away and it just feels like you're breathing normal. Okay. So, simple principles: blowing oxygen. Continuous positive airway pressure. Simple principles: blowing oxygen or air continuously at low pressure into an airway prevents alveoli from collapsing it into exhalation. What's that?
You read that when you said that.
Yeah, you can tell I'm well prepared for the class, right? No, I have not looked at these slides. So, can prevent fluid shifting into alveoli from surrounding capillaries because of the pressure in that alveoli. So if there's no pressure in there, now the fluid can go and fill up, kind of like the partial pressure gradient. So it's a semi-permeable membrane. We have all this fluid out here, no fluid in there. The fluid's going to try to come in to equalize, just like anything else. And so what happens whenever you have CPAP and you have that constant pressure? Now there's pressure in there, and it might be equal, or it might even be more so than what's outside where that fluid's at. So sometimes, or this is why it works so well in CHF. So now you have a higher pressure in the alveoli, a lower pressure outside the alveoli, and so now what's it going to do? That fluid's going to want to go to the lower pressure to equalize. So it's going to go out. You'll continue as your patient it gets better or plateaus off especially on CHF. You'll continue to increase that pressure until you get them to where you want them, which is talking complete sentences. I think we shoot for at least a 96% O2 sat. We're no longer shooting for 100%. But you want them to start breathing normal on their own. Common uses: pulmonary edema, drowning, asthma, and COPD, respiratory failure in general. Let me clarify some things. The drowning. You're actually on the CPAP. You got this patient back, okay? This isn't they're unresponsive or not breathing, and you put it on. You get this patient back through CPR by clearing the airway, and then you put the CPAP on it to help remove that fluid from the lungs. The patient has to be conscious to put CPAP on. You can't put it on an unconscious patient because they can't protect their airway. If they vomit, it's a bad deal. If they're even if they're conscious, vomit, take that CPAP off. Whenever we first started using CPAP, asthma and a lot of your COPD patients were off the list of doing it because they're worried about causing increased trauma to the lung. With COPD, with emphysema, you have less elasticity. With emphysema, the problem is getting the air out, not in. And so the whole school of thought was, oh my gosh, you can't do that. Well, what I found out is the pressure is very minimal at best, and it actually helps them. So the asthma patients, it keeps that airway passages open. So now not only are they getting the breaths in easier, they can get them out easier. So, and then respiratory failure in general. Once again, you have to have a conscious patient. Contraindication, severely altered mental status, lack of normal spontaneous respiratory rate, so they have to be breathing, okay? You can't put this on the apneic patient. Inability to sit up, so they have to be able to protect their airway. Hypotension and shock. And the whole reason for the hypotension and shock is there is the possibility of dropping that blood pressure more, and that's not what you want to do when they're hypotensive. What happens, you affect, I believe, it's the preload by increasing the pressure in the chest, so now the heart doesn't beat as well and drops the pressure further. Nausea and vomiting, obviously, I said that you don't want to put it on a nausea and vomiting patient, cause aspiration, penetrating chest trauma. There's a good reason for this because there's a big hole in their chest. It's really going to cause big problems there. Another thing it do is it cause that pressure into that pleural space, creating a higher pressure into the chest cavity, and then you have you sped up the pneumothorax. Shock, upper GI bleeding, or recent gastric surgery, and then conditions preventing good mass seal. So, like a beard, right? Good mass seal of a beard. A lot of times we're talking about maybe some facial deformities or maybe trauma to the face. So, side effects, and guys, these aren't definite side effects; these are possible. Hypotension, pneumothorax, increased risk of aspiration, and then drying of cornea. Explain procedure to the patient. Start with a low-level CPAP. If you just go stick this on somebody's face without explaining it to them, you're going to freak them out because, as Amber could tell you, it's hard to breathe at first. And so that person's already having trouble breathing, and you don't explain to them, it's going to be a little hard. It's going to feel a little harder to breathe against this at first, and then they try to breathe, and you don't tell them about it. They're not going to want that mask on them, so they just made it harder for them to breathe. But if you explain it to them and you sell the product, most likely they'll allow you to put it on and they'll leave it on. Oh my God. I don't know what that leg that hit by the deer. It just it starts aching real bad. It aches all the way from the
Then you go get something.
only if I knew one.
Yeah.
Man, I need to go have Phil do it. CT on it. That guy just looks like a frog to me. I don't know what it is. Explain. So CPAP. Explain the device to the patient. The mask and snug seal may initially cause the patient to feel smothered and anxious, and it will. That's why you need to explain it to them. Reassess patient's mental status, vital signs, and dyspnea level frequently. Raise CPAP level if no relief within a few minutes. Reassess and monitor the patient. There she is. I'm hoping that if you're doing this, your reassessment is in the ambulance, not sitting in the house. I mean, I'm all about doing some treatments on scene, but man, if you're getting down to the reassessment phase, you already got the CPAP on. Let's be in the ambulance. Let's just go somewhere. It's not hanging out their house all day. You know, his house looks like it's all right. It's like grandma's house. Yeah, I know, right? You're like, No, just keep breathing. Bring me a sandwich. If patient deteriorates, remove CPAP and begin ventilating in bag mask. Oh, that's not good. They did. So respiratory conditions. So chronic obstructive pulmonary disease, COPD, you hear that term a lot. It's a broad classification of chronic lung diseases. That's plural. There's several diseases that fit inside that COPD. Includes emphysema, chronic bronchitis, and black lung. Oh gosh. Really? We're not even in a mining community.
know.
Have you guys seen Zoolander? And oh, come on now. And he goes mining with he's a smell model, and it's funny, him and Hanson. And all he has is blue steel. And anyway, Hanson beats him, and so Zoolander's kind of on the outs, and he goes there, Zoolander. So he goes back home to like West Virginia to the coal mines with his dad and brother, and he's like down there one day. He's like, and anyway, they're at the bar afterwards, and he's like, I think I got the black lung, Pop. It's so funny because he's always been down there one day. So black lung reminded me of that. So
The only thing on the about it.
It was cigarette smoke and
And
black lung. That's all I talked about on the test.
really, that's it? Cigarettes and black lung for COPD or the whole entire test? Oh, okay. Overwhelming majority of cases are caused by cigarette smoking. So if you smoke cigarettes, you need to stop. It's bad for you. Yeah. The chronic bronchitis, bronchial lining inflamed, excess mucus produced, and cells in bronchioles that normally clear away mucus accumulates are unable to do so. Nala, go lay down. Hey, no, go lay down. Go lay down. Quit bugging people. Go lay down. Oh, I'm gonna get you in trouble for petting you. So anyway, here's no, I don't want you to go lay down. Here's a normal lung, mucus plug and inflammation. This is chronic bronchitis, and then decreased surface area from emphysema. So you see how now you have all this nice surface area here, which is the lining. Now you don't have it. You're missing this. That's what is causing it. So emphysema, alveoli walls break down, surface area for respiratory exchange is greatly reduced. Lung loses elasticity and results in air with carbon dioxide being trapped in lungs, reducing effectiveness of normal breathing, lung fish. Chronic disease with asthma, chronic disease with episodic exacerbations. During attack, small bronchioles narrow, bronchoconstriction, mucus is overproduced, results in a small airway passage practically closing down, severely restricting airflow. Airflow mainly restricted in one direction. Inhalation, expanding lungs exert outward, pull increased diameter of airway and allowing airflow into lungs. Exhalation, opposite occurs and air becomes trapped in lungs. So that's why it's, like I said, it's easy for me to get the air in, but not really easy for me to get out. Pulmonary edema, abnormal accumulation of fluid in the alveoli. Patients with congestive heart failure, CHF, may experience difficulty breathing because of this. Pressure builds up in pulmonary capillaries. Fluid, I needed the Red Bull. Fluid crosses the thin barrier and accumulates in the alveoli. Fluid occupying lower airways makes it difficult for oxygen to reach blood when patient experiences dyspnea or shortness of breath. Common signs and symptoms: pulmonary edema, dyspnea, anxiety, pale and sweaty skin, tachycardia, hypertension, respirations are rapid and labored, and low oxygen saturation. In severe cases, crackles in the backholes or sometimes wheezes may be audible. Patients may cough up frothy sputum, usually white, but sometimes pink tinge, has a little blood to it. Treatment: assess for and treat inadequate breathing, high concentration oxygen. If possible, keep patient's legs in dependent position. Their legs hang down. CPAP may be used to push fluid back out of the lungs and into the capillary. Yay, CPAP. Think about it. Might it be possible for a patient to have multiple respiratory disorders? Yes. Could a person with an underlying diagnosis of COPD also have pulmonary edema? Yeah, sure. Infection of one or both lungs caused by pneumonia. Infection of one or both lungs caused by bacteria, virus, or a fungi. Results from inhalation of certain microbes. Microbes grow in lungs and cause inflammation. Signs of shortness of breath with or without exertion. I think I didn't get enough sleep last night. Coughing, fever and severe chills, chest pain, often sharp and sporadic. So I doubt it. Not in here.
We're gonna be ready.
Signs and symptoms: headache, pale, sweaty skin, fatigue, and confusion. Treatment: care mostly supportive. Assess for and treat inadequate breathing, oxygenate, and transport. All right, not a whole lot we could do with a pneumonia patient. Spontaneous pneumothorax. Anybody had one of these? Yeah, that would suck. I've actually had some patients that had spontaneous pneumothorax before, but you've had one?
No.
You have to have a chest tube for it? He'll fix itself on its own?
I do, that's just.
So, lung collapses without injury or other obvious cause. Typically, it's by tall, skinny women that smoke.
Skinny and I don't smoke.
But it can happen with
Here, let me have this.
I'm not.
Oh, hey, look.
I was so good now.
They left off woman. Tall, thin people and smokers are at higher risk for this condition. So, I guess they didn't want to be sexist. Signs and symptoms: sharp, pleuritic chest pain, decreased or absent lung sounds on side with injured lung, shortness of breath, dyspnea on exertion, low oxygen saturation or cyanosis, and then tachycardia. Transport. No, I think it's I just need to stand up and walk around. Treatment, transport for definitive care as patients frequently require chest tube. Administer oxygen, CPAP contraindicated. Bum, bum, bum. No CPAP. So it kind of goes with that injury to the chest wall. You're just going to exacerbate that problem if you use CPAP on them. Yeah, that's fine. Pulmonary embolism. Holy cow. Blockage in blood supply to lungs, commonly caused by deep vein thrombosis or DVT. Increased risk from limb immobility, local trauma, or abnormally fast blood clotting. Pulmonary embolism, sharp pleuritic chest pain, shortness of breath, anxiety, coughing, sweaty skin that is pale and cyanotic, tachycardia, tachypnea, and wheezing. So, fast breath, fast heart, short of breath, short pleuritic chest pain, anxiety, coughing, sweaty skin, and wheezing. Difficult to differentiate and field, transport, definitive care, and oxygenate. I've actually had a lot of people die from PEs, and they don't always meet this criteria. Sometimes it's just confusion. I don't really know why he's confused. Okay, so we transplanted him. He died from PD. That's awesome. I've actually had a few of them like that. They didn't have any respiratory distress. They were just confused. So, infection, epiglottitis. Don't see a whole lot of this. I'm surprised they still teach it to the extent they do. Infection causing swelling around and above the epiglottis. In severe cases, swelling can cause airway obstruction. Signs and symptoms: sore throat, drooling, difficulty swallowing. And when we're talking about drooling, we're talking about lots of drooling. Preferred upright and tripod position, sick appearance, muffled voice, and stridor. Keep patient calm and comfortable. Do not inspect the throat. If they're drooling like that, don't inspect the throat. You can agitate that or aggravate it, and it will shut the airway off. Administer high concentration oxygen if possible without alarming patient. Keep them calm and transport. Don't worry, you're not going to die. You're not. Don't die, okay? Don't startle patient. Cystic fibrosis, a genetic disease typically appearing in childhood, causes thick, sticky mucus accumulating in the lungs and digestive system. Mucus can cause life-threatening lung infections and serious digestion problems. Signs and symptoms: coughing with large amounts of mucus, fatigue, frequent occurrences of pneumonia, abdominal pain and distension, coughing up blood, nausea, and weight loss. So they're typically skinny because of that whole digestive thing. Treatment: caregivers often the best resource for baseline assessment of patient. Caregivers can often guide treatment, assess for and treat inadequate breathing and transport. Some of these diseases like CF, something that you don't see a whole lot, cystic fibrosis, cerebral palsy, things like that. If the caretaker is with them, and they should be on cerebral palsy, but those people are going to be the best source of information that you can have for that patient. They typically know that disease inside and out, and they live with it every single day. Viral respiratory infections. Infection of respiratory tract, usually minor, but can be serious, especially in patients with underlying respiratory diseases like COPD. Often starts with sore, scratchy throat with sneezing, runny nose, and fatigue, fever and chills. Infection can spread into the lungs, causing shortness of breath. Cough can be persistent, may produce yellow or greenish sputum. Oh, that lady's creepy. The prescribed inhaler. So, meter dose inhaler, you'll see it in your text and things as MDIs. Provides a metered, exactly measured inhaled dose of medication, most commonly prescribed for conditions causing bronchoconstriction.
I like those a lot better.
You like those better?
Because I can keep track of how many doses are in the inhaler. Instead of just shaking it and going by, feel or,
Oh, yeah.
You can actually, I can go by both.
Inhaler user problems. Not first world problems.
Far too long.
So, the prescribed inhaler, before administering inhaler, right patient, right time, right medication, right dose, right route, your 5 rights. Check expiration date, shake inhaler vigorously. Patient alert enough to use inhaler. Use spacer device if patient has one. We're about done. Okay. Because I just want to see if we can take a break and then pull up the YouTube video first. So the prescribed inhaler, ensure your 5 rights, blah, blah, blah. There's one with the spacer device, the aero chamber. To administer inhaler, have patient exhale deeply. Have patient put lips around opening. Press inhaler to actively spray as patient inhales deeply. Make sure patient holds breath as long as possible so medication can be absorbed. Don't help patients smoke their marijuana. That kid definitely looks like he smokes marijuana. Hippie. Using a metered dose asthma. What the? I hope you're not going to give a metered dose asthma inhaler like that.
That's not what I did.
That's an EpiPen.
Yeah.
I'm curious now. They piqued my interest. Oh, okay. Are they in the res? You see that guy's glasses? It's like dropping. Yeah. Look at them glasses. I did. But she was still able to control her airway. The small volume nebulizer. Medications used in meter dose inhalers can also be administered by a small volume nebulizer. SVN. Nebulizing, running oxygen or air through a liquid medication. Patient breathes, vapors created. Produces continuous flow of aerosolized medication that can be taken in during multiple breaths over several minutes. Gives patient greater exposure to medication. Review. Hey. Respiratory emergencies are common complaints for EMTs. It is important to understand the anatomy, physiology, pathophysiology, assessment, and care for patients experiencing these emergencies. Patients with respiratory complaints, which are closely related to cardiac complaints, may exhibit inadequate breathing. Rapid respirations indicate serious conditions, including hypoxia, cardiac and respiratory problems, and shock. Very slow and shallow respirations are often the endpoint of a serious condition and are a precursor to death. The history usually provides significant information about the patient's condition. In addition to determining a pertinent past history and medication, determine the patient's signs and symptoms with a detailed description, including OPQST and the events leading up to the episode. Important physical examination points include checking the patient's work of breathing, inspecting accessory muscle use, gathering pulse oximetry readings, assuring adequate and equal lung sound bilaterally, examining for excess fluid, lung, ankle, and abdomen, and gathering vital signs. Determine if the patient's breathing is adequate, inadequate, or absent. Choose the appropriate oxygenation or ventilation therapy. Several medications are available that may help correct a patient's difficulty in breathing. Conditions whether to assist a patient. Consider whether to assist a patient with or administer respiratory medication. Do I have protocols and medications that may help this patient? Does this patient have a prescription? Have a presentation and condition that may fit these protocols? Can't read. Consider whether to assist a patient with or administer respiratory medication. Are there any contraindications or risks to using medications in my protocol? What would you expect a patient's respiratory rate to do when the patient gets hypoxic? What would you guys expect it to do and why? And take on more. But why are we increasing that rate? Because the body wants more, right? It needs more oxygen. So at the current rate, we don't at 80, we're on respiratory rate of 16. We're not providing enough oxygen. The brain's like, hey, we need more oxygen. How do we get more oxygen? Well, there's a few things. One way is to speed up the heart rate. The other way is to speed up the respiratory rate. This is probably going to happen simultaneously. And so respiratory rate increases, heart rate increases. So respiratory rate increases to bring in more oxygen. Heart rate increases to transport that oxygen around faster. So that's what. Make sense? What would you expect a patient's pulse rate to do when the patient gets hypoxic? All right, list the signs of inadequate breathing. Would you expect to assist a patient with their prescribed inhaler when they are experiencing congestive heart failure? Why or why not? List some differences between adult and infant child respiratory systems. All right, critical thinking. A 72-year-old female complains of her severe shortness of breath. Her husband notes she is confused. You note a respiratory rate of 8 breaths a minute and cyanosis. Patient has a history of COPD and CHF. Discuss treatment steps to assist this patient. What do you want to do? Okay. Do we maybe how do you guys want to give oxygen to this patient? Okay. She's only breathing 8 breaths per minute and she's cyanotic.
She's already blue.
Yeah, so we probably want to consider assisting her ventilation, but at 8, definitely. Since you complains of severe shortness of breath, her husband notes she is confused. Ah. All right, good job. All right, take a break and get some videos pulled up. Oh, I gotta stand up and walk around for a minute. Take you know what? Take 10 minutes. I'll get you guys some videos.
I'm hungry.
Oh, no, that's why I said, I know you're busy.
I know if I get my ear, well, fill them through, but not
Whoa,
all.
I'm not, like, lower than one. Now, the lowest mine is got,
Oh, I kind of pulled it up.
and the crackers, they came in constantly.
Oh,
They
All day, man.
they would give you vital for 10 or 2 hours, but they would come in. They were clean it, and check on you.
There's a guy that brings
They're
her,
okay because you.
if they're dancing like that,
But he did, my condition.
they're just wore out.
I had really floated, but I still.
Literally, they were just, they're wore out, and I have to start them.
And.
And they are
They did
hard.
an X-ray multiple times. They.
I told him, I'm ready to get back to me.
Come
I'm like, I don't care if you wear them, but they
That
bring
last
them
time,
to me.
they wanted us, they
I
connected.
was like,
You
please,
said, if we
you
were
don't
going
get
to
hair,
there,
you can't
on
put
the
the
last
mask
one,
on. Your hands to the
that
back,
they're
start
going
them.
to be in.
Like, I'll bring them back.
They can
Oh,
do it. It was just there like 2 hours prior to that.
Start to think like that.
So he had a blessing, and
But you
so.
can't buy them like that. They're actually tore up and ripped. I'm wearing them and starching them. And then he brings them back when you keep on starching them. And I'm like, dude, I ain't starching them again. Don't bring them back. If you do, it's gonna cost a double.
Starching's cool and all, guy, but there's a limit.
blurry up there, or can I just not see anymore?
No, it's blurry.
Okay, good. I really
Why are you wearing a California shirt?
My ex brought it back from you.
Oh.
California.
I just think-
Last year. One, 2 years ago.
I like visiting California this one.
Those nine scenarios today. Here. Kate kind of learned by the book. I get the answers right, but I do it. I mean, the answers are correct, but I do them in a different sequence.
Yeah.
And I'm like, it's in I gotta learn it in their sequence. And I'm like, oh. And you still get to the same point, you know what I mean?
Yes.
I was more fun than the normal 100 questions to get on the test.
So you guys got like scenario questions?
Well, yeah, where it actually gives you more than just
Yeah.
this is it. I like it. It kind of makes you have to think a little bit because second guess yourself on what's the right answer for the patient. What are they really wanting? All these answers can be right, but what are they really wanting? That's how like the normal question, but that scenario taught you, I mean, I like it. After you figured out how it all works out, I mean, that's the first time I figured it out. I like it. Made you actually think like you were actually doing something. But that's what I'm saying. If you were out there actually performing it and doing it, you're still going to get the same outcome if you did do one thing backward or not backwards from what they tell you is right or wrong. So it counted against you if you don't do it exactly what they say. That was my problem. Because what I thought you should do first is what they think you should do in a second, or or whatever. On asking a question, or something. I don't remember what it was. It didn't like kill the patient, but then you get it out of order.
Yeah. You might.
And not on that question. It's really something.
You mess with one in business, do that. You do everything wrong and the patient lives, and you do everything right, the patient dies.
And like on the other test questions when you're doing it, I know they're teaching you the whole, everything that you learned, they're kind of like mixing it in.
Mm-hmm.
But then they trick you because you're like, well, do you do what you learned prior in the other chapter first, or just what you learned in this chapter first? So I'm like, and then I'm like, well, it's just like, it's the whole thing that you learned, so you took that one wrong, so you just learned in this chapter. And then the next time you do that, it's like, oh.
Well, typically what there'll be is a key word on why it's like that. And it goes, like it'll tell you something like, You arrive on scene and find a rollover accident. The scene is saved. What is your next step?
Well, yeah, on the scenario type, that was like that, but like on your regular test question without that, it was like you got a 22-year-old male, whatever, rollover, da. What do you do first? And you could be learning about whatever you were learning about, I don't know. Or say, let's just say, apply oxygen or the airway, or something with the airway, or it says for patient, or do something, and I'm trying to take two and two different chapters.
Well,
And then 1 minute they'll want it thrown together, and then 1 minute they'll want it separate.
how you answer that is you have to know the exact order,
Right.
because there's going to be something in that question.
So that's what I guess I'm not taking up, and what it is in the question is, because I'm not. When I think it's this, and I'm not, no, because we learned this earlier, I'll mark that one, and then bam, I've got it wrong. That's
What-
what my instinct.
What you have to do is keep that order. Remember that your primary survey is really first, so those steps are first. If that scenario has ran you through primary survey, basically, then you're gonna, what's the next right answer, which is airway circulation. If it hasn't ran you through that primary survey, then you need to go ahead and finish up that primary survey before you go neural. And that's what I hope to try to help you guys out.
Because if you're out there actually doing it, you're gonna do it and not even know you did it. But when you're trying to write it down on paper,
But they have to test you
right,
and show that you know. That,
right. I mean, I understand that, but I'm saying you're not missing whatever, because I don't know, you're not missing the key word to pick up what,
yeah.
even though you know what the heck you're talking, you know what's going on. When you're out there physically doing it, like I said, you need 2 or 3 steps in one shot, and not even, realize what you're doing. But that's my problem. I don't think some of those resume test questions, they confuse me. That one about all the assessment stuff, the 101 questions,
Yeah.
by the end of that, I was so damn confused. I was like, I don't even know. Yeah. So they were just asking the same thing over, kind of drill it in your head, but there's that one little. He said, after you don't hang out with the smokers. He's driving by. Not sleeping bad. Learning over the years. In the beginning of these days, I had Christians. Is that the Christian? Yeah. If you knew I was coming out to the house, you wouldn't take him out for that day. You would go outside. Man, I grew up with my dad smoking. Stepmom smoking. Well, and I will not ever. It was so contradicting in my house growing up because Mom smoked, Dad smoked. Mom smoked on Dad never smoked. But the only time I would be told, the only time I was actually away from anything is when they cleaned the fireplace out. Mom would shut the hallway door and make me shut myself in the bedroom. We'll have those until she cleaning out the fireplace and out the house. they smoke in the vehicle with me, they smoke at the house, over the end, over to the oak. You know, that is. I mean,
35?
and you know, mom, when you grab it, you need to do it. You have to take her. You want to have more, you know, time, but you can get them. And I, everything else, it's for that. He grabbed it, and I did see. But I think I'll be out the shoulders.
Put a couple of inches.
Got the laser yet?
You get it?
Oh, yeah. Yeah, I had it on there and stuff that, I don't know.
There was a
Did it do
time
anything?
when, before I had got a big control over it, and they would ask, you know, what's the rating on it? Who's got it? I'm gonna waste my breath. I'm gonna talk to you. But I grew a little bit more patient. I'm minding of it. Hey, my heart.
I said something about having holding and relationships and then it said, oh, look, and it's just so different.
We'll give the Yahoo kind of print and put off the thing. Let's see anything.
You're searching a bunch of websites looking for the best hotel deal. Stop doing that to yourself. Let Trivago
Here's Black Lung.
Trivago compares prices from hundreds of websites.
President Freshman, looking for his All-American John DeRosa, the wide receiver. Got it wide open in the middle of the field. Big rush. Oh,
Who's winning the match?
Travis Conley. Right there, down that.
State.
EMF,
I think I'm getting the black lung pop.
33.
It's not very well ventilated down there. For Christ's sake, Derek, you've been down there one day. Talk to me in 30 years.
Here's
President
Black
Freshman,
Lung.
looking for his All-American John DeRosa, the wide receiver. Got it wide open in the middle of the field. Big rush. Oh,
Who's winning the match?
Travis Conley. Right there, down that.
State. I think I'm getting the black lung pop. It's not very well ventilated down there. For Christ's sake, Derek, you've been down there one day. Talk to me in 30 years.
Late. No, I wouldn't get to it. Well, chess. See as he breathes out, one side expands and one side sinks in. It's paradoxical movement. That's not normal. He is in a bad way. I'm going to show you. So on PEEP, for PEEP is positive. I don't know. Anyway, it's the expiration pressure. It's a positive, so you're breathing against that. CPAP is both pressure when you breathe in and out. This is just an example, kind of what PEEP does with a lung. And PEEP is one side of the
Again, this
CPAP.
is a different angle. Gunshot, Zeep.
So you don't have any PEEP
To
here.
go to 15 of PEEP.
So now you're going to go up to 15. Now see how the lung, whenever it goes down, it doesn't deflate all the way like it was. You're recruiting more of the alveoli, more of the recruiting more of the alveoli here.
And back to Zeep.
Okay, turn it all off. See how the lung completely collapsed.
As you can see, some of the portions are collapsed still, even at peak inspiration.
Yeah.
This one's kind of graphic. Kind of shows you kind of the steps that they're going to go through. Shot him in the leg. You kind of see the stages he goes through. Increased blood loss and responsible. Blood out. Real life scenario there.
Now I'm going to cut your shirt sleeve and make sure there isn't any glass still in the cut.
Did I tell you guys about any other videos besides the teeth and? Well, I said I was gonna play him.
That young cop that is still one of them,
Uh huh.
they got me off, whatever you see is how it's just. That's what they say, that, you got shot twice,
Uh huh.
one in the stomach and one in the hip area, and one in the hip, and it's feeling good out.
You can't stop that either. Surgery is all that you really have to stop that.
They tried to do it.
No, they couldn't.
That would be pretty low.
Like you don't have a heart?
No, to get shot, I mean, that would just be terrible.
I'm not completely listening. I just heard something about a heart and getting shot.
If you got shot in the heart, you probably have better chance of living than in your arteries in your leg. So just because you got shot right there doesn't mean you hit the heart.
So you're saying if you get shot in the chest?
I mean, if you're, yeah, if you're, you got, I mean, if they were aiming right at your heart, it's through your chest, on the same side as your heart.
There's a lot of vessels in your chest.
That's what they think about it. And then I'll be upset. Well, they're gonna be clearing my chest and go ahead and stick my very food. I wonder if they're warranty for gunshots.
Sure. So what's chapter we're going over right now?
We're going to the 18.
Let's talk more about respiratory if we can, because this says we have 33 minutes, and I'm not going to stay here 33 minutes waiting.
33 minutes to download?
Yeah. I forgot to start it. Rob is just a space case. Don't ever hang out with me. I'll lead you astray. Unless you watch this. This is funny. I'm trying to think of some other good.
Oh, what's his place? What's his partner in there? What's the guy with the flat nose? What's his name? Oh, the big nose, the flat nose. He plays in all the movies.
Man, you're just well. Here's a passive high flow oxygenation CPAP lung. Is a kind of a window view on this patient. So I don't know if it's a dead patient.
So this is passive high flow oxygenation using a BVM here with an aggressive jaw thrust and a neural airway. 25 liters via BVM. Not much happening in the lung. It's collapsed and it really remains so. There are nasal prongs on, but there's no oxygen being administered at this point.
Because you're not squeezing it.
What we're using is 25 liters both through the BVM, but also through nasal prongs with a jaw thrust, but no peak. Doing very closely, there's the occasional alveoli that you can see it's being recruited, but not much happening. So what we're going to do is add a PEEP valve and dial it up to 10. And so 25 liters via the BVM passively, 25 liters via nasal prongs, aggressive jaw thrust, and 10 of PEEP. Let's take a look and see what's happening. Pretty impressive, progressively more alveoli being recruited, and ultimately the lung gets completely expanded just by passively applying high flow oxygen through the BVM and nasal prongs with a good jaw thrust and 10 with PEEP. When you let go, it deflates, and apply it, it completely re-expands the lung. So again, let's just take a look. Expands and collapses. Now let's look and see what it would take to re-expand it actively. So just one partial breath re-expands that lung. Now we're going to let go. Lung's going to deflate, and I'll reapply the mask here. Then do a one-handed jaw thrust, mask, hold, and 2 small breaths. 1, 2. Really done with that single breath. That's all it takes.
That's pretty impressive. All right. I guess I'm not going to wait 30 minutes. Or even 6 minutes now. I don't really care. Remember, I need you guys to send me, if you can't do a lab in one of the next 2 week class periods. So look at your schedules, let me know, and I'll reschedule. So we're not going to have a lab on the 20th because we have a couple people that can't. And we will have class, yes. We'll go ahead and have class. Probably what we will end up doing is we will continue on. So on Tuesday. On Tuesday, we'll go ahead and start 18. So it gives you guys all weekend to finish 17 and study 18. Right? Is that what you're doing? But if you can, go ahead and study that, because these are going to airway and cardiac are going to be 2 of your biggest chapters. That's why I don't want to rush through them. Even though we kind of went through the slides really fast, there just wasn't a whole lot I could tell you guys. I mean, try to talk about each slide and everything, but it's something that you guys will have to learn and study. Kind of some important things to do is know how to manage the airway. And so whenever we're talking about airway management, we had the lady with 8 breaths per minute and confused. Is that an adequate rate? And is she affected by it? The answer to both of those is yes. Or no, it's not an adequate rate, and yes, she is affected by it. So yes, we need to assist those ventilations, right? Simply putting on an oxygen probably not going to help at this point. She needs to be breathing faster. And so you guys need to really kind of learn and try to grasp when to use a bag valve mask versus when to use oxygen. Let's say that you have somebody that's having chest pain, shortness of breath, yet they're conscious, breathing at anywhere from, let's say, 10 to 28 breaths per minute. Yes, you're going to go ahead and try oxygen. Once you start becoming confused, and your respiratory rate is either too slow, too fast, or too shallow, that's when you're gonna go ahead and use a bag valve mask and assist their ventilation. All right. Let's see. No, not this Saturday, not next Saturday, but the Saturday after that, right? Yeah. Let's do this. I would. Just see what the YouTube world has. If they got a better.
Did you ever look to see if there's like a practice stuff for the,
Oh, there is. Yeah.
well, I mean, one of
Which one do you use? No, I haven't.
them getting already or something like that?
Yeah, I have one.
Huh?
Hi, my name is Sam, and today I'll be discussing background mask ventilation and a few of the difficulties that we often encounter when ventilating and how we can overcome these. So the QAS advises that BVM ventilation is indicated in patients in respiratory arrest, respiratory distress, and patients requiring assistance for adequate ventilation. While there are no contraindications as such, there are
I'm not very good on the ambulance. I was like, hey, have a medic alert button thing, and I was like, 1:30 in the morning, it's probably 6 in their sleep.
This is a video in clinical medicine from the New England Journal of Medicine. Providing positive pressure ventilation with a face mask and a bag valve device can be a life-saving maneuver. Although seemingly simple, the technique requires an understanding of the airway anatomy, the equipment, and the indications. Developing manual skills is necessary to provide adequate face mask ventilation. While endotracheal intubation is frequently the definitive airway management approach for patients in respiratory failure, it is not always feasible. In these circumstances, ventilating a patient with a face mask can be an invaluable temporizing measure. The purpose of this video is to demonstrate the equipment and technique used to provide positive pressure ventilation with a face mask and a bag valve device.
You're doing one breath every 2 seconds.
Face mask ventilation is used in patients with respiratory failure, but who are still spontaneously breathing, and patients with complete apnea. Face mask ventilation can be indicated after the induction of general anesthesia, the administration of neuromuscular.
I don't like this video. All right, so it is, I guess, good. Let you guys go. Let you guys study this information over your Easter weekend rather than hunt Easter. Study. Out there in the internet's land, do you guys have any questions for me?
So we're not going to do the lab on Thursday?
No, we're not.
Okay.
I want everybody to send me a date if they can't do it on a certain date, and then I'll schedule it. I know that we can't do it that Thursday. But.
I've already sauteed my garlic and onions, threw in my Brussels sprout slaw.
All right. See you guys later.
Immediately,
All right.